Hello, and welcome to another Rush Generations Health Education lecture. Um, Rush Generations and our staff is delighted to be your source of information, resources, and health promotion programs that help maximize your well-being and good health as you age. Today is Wednesday, April 15, 2026. I'm Grisel Rodriguez Morales, Rush Generations Program Director, and I'll be your moderator for today's lecture, Health Vision in Later Life. And before I present to you the wonderful speaker that is joining us today, I like to first thank our producer, Hannah Weitzman. Besides getting us here today, Hannah will be helping us manage the chat and other key aspects so that we all can have a great discussion about vision health in older adults and how to protect your eyesight as you age. As always, we're live streaming this lecture via our YouTube channel using the video platform Zoom, which also allow us to host a good number of people who join us via phone. By the way, thank you for joining us. For those of you on YouTube, we ask that you please use the chat function to ask questions and or to add to the discussion throughout the lecture. We are going to make sure that your comments and your questions make it to the presenter. And for those of you listening to the discussion via phone, you will have also an opportunity at the end to unmute your audio so that you can ask your questions. We like to remind you that all the information that is offered here is for general informational purposes only and to always seek additional professional advice for situations that are specific to you and your needs. Okay, so today we have Dr. Murphy, Dr. Terence Murphy, who is a chief resident of ophthalmology here at Rush University Medical Center. He completed his medical degree at Rush Medical College and a master's of public health at St. Louis University. He completes his training, his formal training this June, and will join. We're very happy that he will be joining the University of Ophthalmology Associates, a clinic which is a private practice that is affiliated with Rush here on the main campus. And he will also be an assistant professor in the Department of Ophthalmology, focusing on primary eye care, refractive surgery, sustainability, and resident education. So thank you so much, Dr. Murphy, for agreeing to speak with our audience. And the floor or the screen is yours.
Thank you very much. Good afternoon, everyone. I'm very happy to be here and to chat more about visual health and aging. And after I go through my slides, it sounds like we'll do some question and answer. So I'm happy to answer any questions people have. So first, wanted to start with generally, some recommendations from the American Academy of Ophthalmology and other eye care organizations about visual health. And so specifically, people often ask, how often or when should they have an eye exam? Typically, we recommend a baseline eye exam at the age of 40 and a complete eye exam at that time. And then between the ages of 40 and 54, an exam every 2 to 4 years. From the age of 55 to 64, an exam every 1 to 3 years. And then pretty frequent exams after the age of 65, every 1 to 2 years. Annual exams are recommended for anyone that has diabetes, whether type 1 or type 2, for contact lens wearers, and then for anyone that has a strong family history of eye problems, such as glaucoma, macular degeneration, cataracts, or other conditions. And there are different types of eye care providers. Usually either an ophthalmologist or an optometrist will do. Often we get asked about the difference. So ophthalmologists such as myself have undergone medical training, so a medical degree, um, and then undergoes an additional 4 years of specific eye and vision training. And we get prepared during that training to do medical care and then also surgical care of the eye. Optometrists, after completing college, they spend several years completing training in vision correction and some medical training in the eye. Um, the one other difference between the two is that ophthalmologists take health insurance, so Medicare, Medicare Advantage plans, and private health insurance. Optometrists often and usually require a separate vision insurance. And then as whether you see an ophthalmologist or an optometrist, the general eye exam that you receive should include several things. First, checking your visual acuity, so how sharp your vision is, your eye alignment, your color vision. You should have what's called a slit lamp exam, which is when we use a special microscope to look at the fine details of the eye. We check your pupillary reaction, so how your eye reacts to light. We check your field of vision, so to make sure that you're seeing not only sharply and clearly, but everything that you should. That does get important for driving and driving exams. We also do what's called refraction, which is checking your eyes for a glasses prescription or a contact lens correction. And then we also check eye pressure. Okay, and then some things that should prompt you to have an exam sooner than an annual exam would be the following. So sudden onset blurry vision or vision loss, so the eye going, or the vision going black or gray. Flashes of light in your vision, kind of like a strobe light is going off to the side. A burst of new floaters. So I tell people not just the classic kind of squiggly line or two that you might see in your vision, but like hundreds of gnats in your vision. Eye pain or eye injury. So any of those things should prompt you to see an eye professional pretty quickly. There are different ways to do that. Here at Rush, we have 2 clinics that offer same-day appointments. Eye center physicians and university ophthalmology associates. Both of those practices are in the professional office building and on the 9th floor. And then after hours, the way to receive eye care if you have one of these issues would be through the Rush emergency room. Some general eye care recommendations that we often discuss are regular eye exams so that we identify any problems early that might need treatment. Wearing UV protection, especially when you're out in the sun for long periods of time. Staying hydrated so that you prevent dry eyes. Generally living a healthy, physically active life. Knowing your family history, so you're aware of eye conditions so that we can catch them earlier. Taking breaks and blinking frequently are important, especially if you're spending a long time at a screen, whether that's a phone, a tablet, or a TV, is helpful to relax the eye muscles and then also to blink frequently and prevent dry eye. Eating for your vision, which we'll get into in another separate slide about some specifics that you can do to prevent issues and benefit your eyes. Not smoking is also very important and helps ensure that there's good blood flow to the eye. And then sometimes not mentioned, but very important, is using safety glasses when doing any manual labor. I tell my patients, even if you're not expecting something to happen to your eye, or you don't think that you're doing something that might cause damage to your eye, something as benign as mowing the lawn can and has caused eye problems. So throwing on a pair of safety glasses is always a good idea. Next, I wanted to talk a little bit about nutrition and some different things, different things you can eat that can prevent and prevent eye problems and promote vision health. So vitamin C is a very important antioxidant for the eye. It reduces the risk of UV light damage, so it can slow down the progress of cataracts, and then also limit the damage that UV light can cause that precipitates macular degeneration. Some good sources of those are citrus fruits, strawberries, tomatoes, peppers, and broccoli. Vitamin E is similarly a very important antioxidant for the eye and has similar benefits. That can be found in almonds, olive oil, and avocados. Lutein and zeaxanthin are important antioxidants and pigments that filter blue light, and specifically research has demonstrated that they reduce the risk for macular degeneration. Those can be found in leafy green vegetables, broccoli, asparagus, raspberries, papaya, and mango. And then lastly, omega-3 and omega-6 fatty acids support retina function, reduce the risk of macular degeneration, and also help with dry eyes. Those can be found in salmon, trout, sardines, walnuts, and sunflower seeds. My hope is that your takeaway from this slide is that there are many things that you can eat that can benefit your eyes. And if limited by what you can ingest, so mechanically, what you can chew and what you can't, there are options at your local pharmacy for supplementation, whether it's a vitamin or like a fish oil capsule is a good supplement for fatty acids. Next, I wanted to spend some time discussing some common eye conditions, things that you should know and be aware of that are common in older age. Some are preventable, some are not, but whether or not you have them, your eye care provider will be able to identify them and help you navigate, the process of treatment if necessary. The first condition that I want to talk about is very common, and that is cataract. Cataract is when the natural lens inside the eye gets cloudy with time and with age. I tell my patients the reason why that happens is because the lens inside the eye is actually pretty akin to the tree, to a tree trunk that gets a new ring and a new layer added to it every year. The same thing happens to the lens inside the eye, and unfortunately, that eventually causes it to become cloudy and or hazy. And the effect of that is that it can cause blurry vision that doesn't improve even with a good pair of glasses. Usually the first signs of cataracts are in around the age of 60, sometimes earlier, sometimes later. The good news about cataracts are that they're very slow and generally don't require urgent intervention. I included in a slide here, a depiction of what vision might look like with a cataract. There's a sunflower here on the left, nice crisp detail with normal vision in eyes unaffected by cataract. And then on the right side here is what that same sunflower might look with a cataract. And so you can see it's fairly blurry and foggy. And again, even with a good glasses prescription, the fine details of the image might not be identifiable to those with a cataract. Apart from just blurry vision, a very common complaint that we receive from patients is glare from bright lights, especially at night. And a common complaint is that patients start to have difficulty navigating their environment at night, specifically driving. And that, even if you don't have blurry vision, glare would be a reason to treat the cataracts if it is starting to affect you and your life. So unfortunately, there isn't great prevention for cataracts. Some of the things we mentioned earlier about blocking UV light and the things you can eat, so research suggests may slow down the progression of cataract. Um, there are some risk factors for the progression of cataracts apart from age, including smoking and diabetes, and some medications such as steroids. The real treatment for cataracts is surgery. Surgery is a pretty quick outpatient procedure, takes about 15 to 20 minutes. It's very safe and low risk, generally is painless, and doesn't require much anesthesia in most cases. Vision improves within just a few days. It's not uncommon for patients to return to 20/20 vision within 2 to 3 days. And we don't do the same eyes, both eyes on the same day. We separate them by about 2 to 4 weeks. I included in our slides here some pictures of what surgery looks like. The cloudy lens is cleared out using a small special ultrasound and vacuum device. And then we implant in the eye an acrylic clear lens that lasts you the rest of your life. And again, overall, very safe procedure. When we do surgery, you do get an option about the implant that goes inside your eye. That is an item of discussion for you and your surgeon, but wanted to let you know that there are some options. Some of those options are covered by insurance, like a standard monofocal lens that gives you good vision at a particular distance, either at near or far away. And then there are some specialty lenses that are not usually covered by insurance that give you more range of vision, and that usually translates into what we call spectacle independence, or really just needing glasses less often. And just so you know, the average age of needing cataract surgery in the United States is about 72, though again, some people need surgery earlier and some people later. Next up, we have macular degeneration, a common condition that lots of older folks hear about but don't always know what that is. So the macula is a part of the retina. The retina is the wallpaper of the back of the eye, and it's akin to the film of a camera, if we think about the eye like a camera. And it's the macula itself is in the center of the retina and is responsible for the sharpness of your central vision. Macular degeneration is an age-related process where proteins deposit in the macula and can distort their shape. That can affect your vision by causing wavy, distorted, or even blurred vision. In worst case scenarios, it can cause basically a blind spot or a darkening in the center of your vision. I included in our slides here some visual examples of what that might look like. So here we have a normal eye with normal vision, so nice crisp image of some trees here. In the second set of photos, I included some early, what we call dry macular degeneration, where there are protein deposits. And in the picture of the tree, the visual depiction here, you can see that there is some blurring and some waviness or distortion of the image. And then in later stage macular degeneration, or in some instances, what we call wet macular degeneration, the wet referring to some bleeding that can happen in the back of the eye. That is more extreme and can cause central vision loss. So in the picture here, depicting the vision that might result from this pathology, you can see there's this dark or black spot in the center of vision. So what are some risk factors for macular degeneration? We touched on age very briefly. So 10% of adults 65 and older have some form of macular degeneration. 30% of adults 75 and older have some form of macular degeneration. Cigarette smoking is known to be a very significant risk factor for macular degeneration and doubles the risk of it developing. There are some genetic associations. Poorly managed blood pressure and cholesterol is also a risk factor. Caucasians, so white folks are more common or more likely to have macular degeneration. Women have higher rates of macular degeneration, and so do people with light irises, so blue or green eyes. General methods of prevention. So we recommend that if you smoke, you try and stop to keep your blood pressure and cholesterol as tightly controlled as you can. And then dietary antioxidants and omega-3 fatty acids are very important, which we highlighted in our slides a little earlier. There are multiple stages of macular degeneration. Some require treatment and some do not. The earliest stages and the mildest form do not require any treatment, and we just monitor for progression. After that, depending on the degree of protein deposits and whether there is bleeding in the back of the eye or not, we may recommend a special vitamin formulation and or injections in the eye. The injections in the eye are reserved for patients that have active bleeding, and those injections help clear up the blood. Again, getting a regular eye exam with either an ophthalmologist or an optometrist is very helpful to identify these problems early and start treatment if necessary. You'll find that that's a theme for my talk today. Next up is glaucoma. So glaucoma is a condition that affects the optic nerve. The optic nerve is the connection between the eye and the brain. It functions as kind of like a cable between the eye that acts like a camera and the brain that's acting like a computer. It is very slow and progressive and is usually associated with high eye pressure. Glaucoma is known as the silent thief of vision in the ophthalmology world because there are often no symptoms early in its process. It doesn't typically affect central vision first. It usually affects peripheral vision. So people may not notice that they have glaucoma until some things start happening, such as they'll come in saying, I keep bumping into door frames, or I've gotten into multiple car accidents now, and I'm not sure why, or I keep missing stop signs, and I'm not really sure why. And I've included a visual depiction here to demonstrate. So normal vision would be, and unaffected by glaucoma offers this full field of vision where the peripheral vision is not affected. But then here on the right side, I've included a picture that depicts vision that has been affected by glaucoma. And you can see that there are pieces of the vision that are missing, that are black, and then some areas that are blurred. In advanced disease, there can be central vision loss and even permanent blindness. So again, good to get a regular eye exam for this to be identified early. Risk factors for glaucoma include high intraocular pressure, which an eye doctor will be able to identify for you. It is a relatively common condition affecting 2% of older adults, so adults 65 and older. There are different forms of glaucoma. African Americans are more likely to be affected by some of those forms than Caucasians or Hispanics. Family history is very important. It's well established that parents that have glaucoma, their children are more likely to get glaucoma. And then diabetes may or may not be a risk factor for glaucoma. I've included it here in our slides, but there is some debate and research is inconclusive about whether or not it is a risk factor. Prevention and treatment includes lowering intraocular pressure, which your eye doctor can help you do. There are multiple options for how to do that, whether it's with lasers, eye drops, or surgery in later case scenarios. Again, knowing your family history is really important. And I recommend to any of my patients that if they find out or if we diagnose them with glaucoma, I ask them to please let their siblings know and to please let their children know so that they can be screened for it and follow up with an eye care provider. Next up is diabetic retinopathy. So diabetes is a condition of insulin resistance where there are high levels of blood sugar in the body. How this affects the eye is that it can damage the small blood vessels that help bring oxygen and nutrients to the entire eye, but especially the back of the eye. I've included a picture here of a normal retina. So the retina, if you remember, is the wallpaper, the back of the eye. And then I've included a photo here of what the eye looks like if it's been affected by significant diabetic retinopathy. So there's some bleeding here, and then some exudates of a proteinaceous-like material. The damage that diabetes can cause to the eye can cause leaking of blood vessels, bleeding, and in worst case scenarios, retinal detachment. So the retina coming off the back of the eye. It can cause blurred vision, loss of portions of the vision, and in some extreme cases, profound loss of vision and even blindness. I've included here a photo of what normal vision would look like, and then a picture also of what some pretty significant diabetic retinopathy what the vision might cause, which you can see here are some missing spots of the vision and/or some generalized blurring. So what can you and what can your eye doctor do for diabetic retinopathy? Well, the first step is really blood sugar control. So we have found that keeping the A1C, which is your average blood sugar, below 7% significantly reduces your risk of diabetic retinopathy. There's a 40% reduction in the prevalence of diabetic retinopathy if we get the A1C below 7. Controlling blood pressure is also very important. Any blood pressure over 130 over 80 can accelerate the blood vessel damage that leads to diabetic retinopathy. Again, quitting smoking is very important. Smoking winds up being a stress on your blood vessels that can be prevented and or avoided. We recommend annual eye exams for anyone with diabetes so that we can identify and treat diabetic retinopathy if it's present. And often people will ask, even if they don't need treatment yet, what that treatment looks like. It's usually either laser treatment to the back of the eye to help avoid further damage. And then sometimes we use injected medications to control bleeding if it looks like it might affect vision significantly. Next up, wanted to talk about a little bit more of a benign condition, but very, very common is dry eye syndrome. Honestly, not just in older adults, but usually more frequently. Dry eye syndrome can be very, very bothersome and very irritating. It's caused by a reduction in tear production or a change in the tear quality. It's more common in folks that are older than 65 due to hormonal changes and is prevalent as 15 to 20% of the older adult population. Some signs and symptoms of dry eye syndrome include intermittent or blurring or chronic blurred vision, glare or halos around lights at night or even during the day, Common is also tearing, which sounds counterintuitive. The eye often tears more with dryness because the eye is creating more watery tears reflexively because the natural oily tears are not being produced in the volume or the quantity that the eye needs. Redness is also very common. Um, Irritation and often a sharp stabbing pain is what patients might experience. And then mucus and or crusting around the eyes, especially in the morning, is very common. There are different things that you can do to prevent dry eye syndrome, like staying hydrated, using a humidifier in the winter. And then some common treatments that we recommend are artificial tears, which which act sort of similar to like hand lotion for dry skin. So it's something that you can apply when your eye is irritated. Those are sold over the counter at any pharmacy. And I would look for specifically something that says artificial tear. You want to avoid any drops that say redness reliever, because those can actually make dry eyes worse, because they have medications in them that do turn the eye more white, but those medications can actually dry the eye out more. So looking for something saying artificial tear is great. I would avoid using something like a Visine. Hot compresses are very helpful. We have oil glands that line our upper and our lower eyelids. Hot compresses help melt the oil inside them and help the oil come out and lubricate the surface of the eye. Omega fish oil supplements are very helpful. They help improve the quality of the oil that our eyes are producing. And then lastly, if you still have significant dry eyes and they don't seem to be improving with some of these things that you can try at home, your eye doctor can prescribe medicated eye drops, which help increase the amount of natural tears that your eyes are producing. You may have heard of some of those on commercials like Restasis or Xiidra. They work by reducing inflammation in the eye and again, increasing the natural tears that your eye is producing itself. Next, a very common condition, albeit very bothersome, are floaters. So inside the eye, behind the white part is a jelly. It's called the vitreous. I have a picture up here on our slides showing kind of what that looks like. It fills the back of the eye when we're born. And when we're born, it's clear and it's kind of like fresh Jello right out of the fridge. It's nice and firm and it stays attached and it's nice and clear and jiggly. As we get older, the gel starts to form pockets of fluid, starts becoming softer, and also sometimes clumps of little proteins develop. Unfortunately, those proteins and the pockets of fluid can cast shadows. Those shadows are what we see as small kind of little squiggly lines, or sometimes people will describe kind of spider webs in their vision. I've included in our slide here a depiction of what that might look like in your vision. Generally, nothing to be concerned about. Sometimes people are very, very bothered by them. They can get worse sometimes after cataract surgery. If you are bothered by floaters, there are some different things that we can do about that. Unfortunately, there's no well-established form of prevention for floaters, but there are cases where we can do a surgery to remove the jelly from the back of the eye. And there are also some newer laser procedures to help kind of break up some of those pockets of fluid and move the protein clumps out of the way from the center of your vision. We do generally reserve either surgery or lasers for cases where it's really very bothersome and people really just can't tolerate their floaters and it's really preventing them from living their life. But generally, they're not very bothersome, and neuroadaptation, basically, you kind of get used to it, is generally, the party line is generally what it generally does cause improvement over time. Noticing floaters is more common when out in bright light, when looking at screens, and then also when looking at the sky. One word of caution that I do want to give is that floaters can be a symptom of more serious eye problems, like a retinal tear or detachment. However, those floaters are generally different than the visual depiction that I showed in the last slide, where they look like little kind of squiggly lines. Floaters that should prompt you to see an eye doctor emergently or very urgently would be if they were preceded by flashing lights in your vision, or if there's a sudden burst of floaters in your vision that looks like a cloud of flies or gnats in your vision. Or I also describe it as though your eye is a snow globe and you're having a really hard time seeing through it. That would also be akin, or that would also be a sign that there might be more serious problems going on in your eye. Again, that should cause or that should prompt you to go see an eye doctor, ideally within about 24 hours if possible. So, several themes in today's talk. I wanted to impress upon everyone that seeing an eye doctor, usually every 1 to 2 years over the age of 65, is really important to your visual health, and to identifying, preventing, and treating any problems before they become really big problems. We have a great eye care team here at Rush that's usually pretty accessible. There aren't many places in the city where you can walk in and see an ophthalmologist, but we have 2 places on campus that can see patients urgently if need be. And we're always happy to see a new face. I just wanted to include here a cartoon that I always find that I have printed and up in my exam room of Mr. Potato Head kind of struggling to see his TV here, and reorganizing his limbs to see his TV. Often patients will come in that they'll be avoiding coming in to see the doctor and kind of going through great lengths to do so, even though their vision is really affected, when something as simple as maybe a new pair of glasses can solve the problem. So I wanted to thank everyone for listening to my talk today. If you are looking to establish care and find a new eye doctor, we have a team of about 10 or 11 doctors at Rush, and who also go to many other locations that I've listed here, including Skokie, Vernon Hills, Oak Brook, and we'll be opening up an Elmwood Park location soon. And with that, I'm happy to take any questions that anyone has about their eyes or their vision.
Thank you so much. Thank you so much. This was great. I was glued to the screen, listening to everything. And we have great engagement in the YouTube channel, several questions that have come up. I wanted to open it first to our callers. This is the time that we also provide for you. You can dial *6, and that way you can be unmuted. So feel free to do that. And while they think about that, before we proceed with questions, actually the floaters was what brought me to your clinic. I remember. That was very scary.
Very common.
All of a sudden I started to do this with my hands, like what is in front of me? I mean, I was very out of the blue, unexpected. And it was that flashing light that I said, I think I need to get this check right away. So thank you for that. I wanted to start with some questions. If the colors are not unmuting, when you're saying the eyes exams, anywhere between 1 year or three for those that are 55 and 64. That is regardless if people use eyeglasses or not, right? That's a recommendation?
That, yes, that is regardless of whether people use eyeglasses or not. We, especially in older age and after the age of about 25, glasses prescriptions don't typically change that frequently. And so it's not necessary to have exams annually as long as you feel like your vision is pretty good. But if you are experiencing changes in your vision, or you think you do need an updated glasses prescription, then you should come in.
Okay. So that's when then the variance, it can be every year, but also you can weigh up to three if nothing changes.
Absolutely.
Okay, good, good. All right. And then in terms of the most commons, the glaucoma, cataracts, macular degeneration, that's usually you get one or the other. I mean, or is it possible that you can suffer from more than one?
Unfortunately, it's possible for you to suffer from all of the things that I talked about today, all at the same
Oh,
time.
wow.
Having one of those conditions does not, unfortunately, preclude you from having another. So it is possible to have cataracts, macular degeneration, glaucoma, all at the same time, which is, why it's so important to see an eye doctor to identify those problems.
Oh my goodness. Okay, all right. So thank you, Hannah, for sending me the questions from YouTube. Is the a question about medications. Do the medications affect eye health?
So medications can affect eye health. It depends on the medication. Usually your prescriber will let you know if there's a specific condition that they have in mind, or if they recommend an eye exam. Some examples of medications that do need a regular eye exam include hydroxychloroquine. It's also called Plaquenil, which is a medication that can cause damage to the retina or the back of the eye. There are some medications that can cause damage to the optic nerve. Often those are antibiotics that people are on for long periods of time. So that would be a reason to potentially come in and get an eye exam. There are also many medications that are used for cancer treatments that can cause not only dry eye, but surface disease. So basically like eye surface problems. And generally, if your oncologist or your hematologist is starting you on one of those cancer therapies, especially those that are known to cause eye surface disease, they will give you a referral to an ophthalmologist and send you right over.
Thank you. And I'm watching the time, but I think we're good in time. We have a few others. What is ICE syndrome?
Oh, ICE syndrome? ICE?
ICE or ICE syndrome.
ICE
The
syndrome.
ICE
See here.
iridocorneal endothelial.
So ICE syndrome is a relatively rare condition that affects the anterior segment of the eye. So when we say anterior segment, we mean the cornea and the iris usually. And it's a progressive condition that usually affects not always, but usually affects women, and it usually affects one eye. It is something that would and is associated with glaucoma, and sometimes needs pretty significant treatment, like corneal transplants and or glaucoma surgery. If you have ICE syndrome in your family, you should have an ophthalmologist see you, and they can usually identify whether it's happening pretty easily, and then can talk to you about treatment options if you need them.
Excellent. Yes, call the clinic. I remember that day I got an appointment and it was later. I'm like, oh, I really would like to see uh, someone today.
Mhm,
And
mhm.
then I was told about the wait list. Like you can go come in the afternoon. And I'm glad I did because I was able to know what was happening within 24 hours.
Yes.
So don't hesitate to ask more questions and to do what's best for you. Another question, when black dots suddenly appear in one's vision range, what kind of disorder is this? Black
So
dots.
there's a few different things that can be. So if you're seeing black dots in one eye, and it's sudden and there's many of them, it could be one of several different things. The jelly in the back of the eye, like we were talking about earlier, the vitreous, sometimes the vitreous, the jelly pulls away from the back of the eye, and it can cause black dots in your vision. Sometimes those black dots, it can actually be blood in the back of the eye. And that might be associated again with the jelly coming off the back of the eye, or could be associated with diabetic retinopathy, and there's new bleeding in the back of the eye. Black dots in your vision could also be there are some uncommon inflammatory conditions that affect the retina and the blood flow to the retina, which would be identifiable on exam. So new black dots, especially in one eye, should prompt an eye exam so we can tell you what's going on.
Got it. Got it. Thanks. When will one consult a retina specialist?
Good question. So that does depend on your primary ophthalmologist's or your optometrist comfort, with treating retina disorders. Usually, ophthalmologists will see patients with retina disorders and will consult or refer you to a retina specialist if they think that you need treatment like an injection into the eye, a laser treatment to the eye, or if you have a more serious and urgent retinal problem that needs surgery, like a retinal tear or detachment. Some eye doctors, when they see very early signs of retina problems, will send their patients to see a retinal specialist early. It does depend a little bit on the eye doctor that's seeing you and what their comfort level is to,
Mhm.
to manage and to monitor chronic conditions that do not need treatment.
Excellent. Excellent. There's a question, and I wanted to also tie it to this picture. The picture that you showed painted quite a picture or scenario in which the vision with glaucoma, things that disappear
Mhm.
from the peripheral view. But one of the color, or one of the someone in the audience is asking that they are noticing that when they drive at night, the vision is not the same.
Mhm.
And the question is this due to aging?
Probably it could be due to aging. It's probably related either to cataract or could be glaucoma, but cataract is much more common. So cataract, because of the clouding of the lens in the eye, it causes distortion of light as light is moving through the eye and can cause a few things, not only blurring of vision like we talked about, and not only glare off of bright lights. It can also cause a reduction in what we call contrast sensitivity,
Mm,
which is the ability for us to identify differences in color or differences between and dark, light and dark objects. And that loss of contrast sensitivity is very pronounced at night when there's low levels of light and there's a cataract in the eye that's preventing the light that there is from getting to the back.
good, good. Thank you so much. Okay, since you spoke of cataract, this is one of the last two questions that we have for you. How soon should you recommend cataract surgery?
Good question. So cataract surgery, we typically recommend it if it's affecting your vision, such as causing blurry vision, or it's affecting your vision, your vision in a way that's affecting your ability to do the things in your general life that you like to do. So while we do examine you, and when we do a full exam, we check the sharpness of your vision, we check you for a glasses prescription, and then we also do an exam and with our microscope, and we look at what the cataract looks like, and we do typically document, the size and the shape and the color. But it's not only what we see in the microscope that determines when we go to surgery. It is also how it's affecting you and your vision. So ultimately, cataract surgery is a decision that we get to make together, both you and your
Mm-hmm.
doctor. It's a conversation. And, often people will talk about the ripeness or the readiness of a cataract to come out of the eye. That's a little bit of an antiquated, way of thinking about cataracts, because it's really, once it's affecting your vision in a negative way, to a degree that's impacting you in your life, that's when we do cataract surgery.
Yeah, beautiful. Yes, we have been focusing so much in healthcare about what matters to people, what matters most, and if um, depending on what are your priorities and what is important to you in your life, it's important to have those conversations as well.
Mhm.
Okay, and the
I have
last
a
one is about
question.
oh, go ahead. Yes, thank you.
Okay. I wanted to ask about when you have dry eyes, you were saying you should buy the drops that says artificial tears, or
Yes.
if you just buy what it says dry eye lubrication, is that equivalent to the same thing? And if you use the drops, how often would you use the drops daily?
Great question. So yes, those two are akin. Often these companies will use different phrasing, but those are similar or the same. Those are the same.
Okay.
And then also relating to that is you'll probably see lots of different brands out there. You'll go to the pharmacy and you'll see 10 or 20 different types of eye drops. I typically recommend that people use one of the branded versions. The reason why is because some of the generic, like the Walgreens branded or the CVS branded, they wind up getting sourced from foreign countries where the safety standards are not as rigorous. So in the last 4 years, there have been two very big outbreaks of bacterial infections associated with the generic brands of eye drops. So I would go with something like a Systane or Refresh or Blink or Avisia. Those are all very good. And then as far as the frequency that you use them, I typically recommend that people start around 4 times a day, and they can either increase it or decrease it, depending on if they feel like that's helpful or not. Um, Going over 6 to 8 times per day is not necessarily a problem. However, some of these drops do have preservatives in them. And if you use them more frequently, sometimes the eye can develop an allergy to them. And so again, I typically say about 4 times a day and then kind of go from there.
Okay. Thank you.
You're welcome.
Thank you. Thank you for the question. Okay. So, and you mentioned at the end the other locations. We have the Eye Center at Rush. That will be the main location. And what are the other offices? Because somebody's asking about if there are other offices. You
Yes.
mentioned.
So the resident clinic is the eye center at Rush, and
Mhm,
then the other practice that has multiple locations is called University Ophthalmology
mhm,
Associates. or UOA for short. All of the doctors at that practice are on faculty at Rush, and we have locations at Rush in Skokie, in Vernon Hills, in Oak Brook Terrace, and then there's a new location that will be coming soon in Elmwood Park.
Excellent, excellent. Well, thank you so much. And I can tell the audience the exam was quite extensive and comprehensive, from pressure to the slit lamp exam, all of that. So I was quite pleased, and I'm delighted that you accepted our invitation to present today. Please share this with your friends, your family. I'm glad there's some connections also with other things. We talk all the time about nutrition and, other things that we can do, like smoking cessation, how important that is, and using tools like the safety glasses you mentioned. We can stay healthy and for many decades to come. So thank you so much. Appreciate your information for being here. And now we're gonna let you know about what is coming up at Rush Generations. We have next month is Older Americans Month, and the theme this year is Champion Your Health. And we're going to be hosting events throughout the whole month, next month, to celebrate Older Americans Month. So I hope that you're getting our newsletters in e-newsletters so that you can know everything about it. One of the first programs that we have for Older Americans Month will be the Shaman Senior Voices Thought Leader Lecture. This is going to be our third annual Shaman, no, actually our fourth annual Senior Voices Thought Leader Lecture, Finding Grace and Support on the Dementia Caregiving. Dr. Fyron Epps, who is a nurse scholar, is going to be sharing her research experiences walking alongside African American families affected by dementia with an approach that is grounded in faith, service, and community wisdom. And is going to be held on Wednesday, May 6th at 12. So it's a little bit of a change of time. So pay attention to that, 12 p.m. to 1:30. And it's going to be streamed virtually through our YouTube channel. You can always call us at 1-800-757-0202 to register. Then we are going to also have our annual resource and health fair, Stepping into Summer. The Stepping into Summer Health Fair will be held at the Sankofa Village Wellness Center. It's not on the main campus, but it's very close to us. We are one of the partners at Sankofa Village Wellness Center, and we're going to host it there from 9 a.m. to 12:30 p.m., where you can join us on the dance floor as well for some Chicago-style stepping. But of course, we're going to have not only the stepping instructions, but also we'll include numerous health screenings, a sleeper exchange, and many tables with information on services to support your well-being from our community partners and providers. Shaman Senior Voices, which aims to empower older adults to discuss what matters most to them as they age. We'll love to hear from you. We'll love to learn from you. So please consider sharing your wisdom on why it is important for your healthcare team and your loved ones to know your goals and your wishes and what matters most to you. You can scan the QR code, the quick response code, to record on a mobile device or a smartphone. Then next lecture is going to be in a couple weeks, allergy awareness and respiratory health. We'll remind you once again there about the upcoming programs that we'll have during Older Americans Month. But for now, we wish that you join us on April 29th. And don't forget to call us at 1-800-757-0202 if you would like to know more about the Rush Generations programs or will benefit from speaking with one of our clinicians. Thank you so much.